go ahead and get started. Thank you all for being here. I'm delighted to welcome you to this episode of Chat with Chat, the iConquerMS webinar series to share new knowledge that's being gained through the participation of our members and our research partners. I'm Holly Schmidt, and I'm co-chair of the iConquerMS Research Committee. Just a couple of quick reminders. If you, but please keep your Zoom chat, I'm sorry, your Zoom muted during the presentation. That would be great so we can eliminate the background noise. And also, there's a chat button there. And if you would like to ask questions along the way, you can use that and type in your question. I see a lot of familiar names on the list, but there also might be some who are new to or unfamiliar with iConquerMS. So I'm going to share a few quick slides showing all the ways that being an iConquerMS member empowers people to make a difference. The first up is our iConquerMS Our Questions Have Power program, in which iConquerMS members are invited to share their research questions and ideas and to vote on the ideas that were submitted by other people. And this is a great way to shape future iConquerMS research and have an impact on the knowledge that we generate in the future. Our current topics that are up for proposals and for voting and comment are MS symptoms and their treatments and management, as well as COVID-19 and MS. So if there's anything that you're curious about in those two areas, then please consider writing them up for Our Questions Have Power. And next up is the CoverMS study, which is a study about COVID-19 vaccines and how they're working in and affecting people with MS. And I wish, and I'm sure we all wish, that COVID-19 was over and done with, but unfortunately it is not. So we need to keep learning about the best strategies for keeping people with MS safe. We just launched a sub-study for CoverMS participants where we're studying the immune responses to the different vaccines in different people. And our participants are being invited to contribute blood samples, and they're receiving their antibody results in return. So if you're participating in CoverMS, thank you. And if you're not, the study is still open to join, so I hope you'll consider doing so. And then finally, the iConquerMS Survey Center has frequent opportunities to make a difference throughout the year. We have an ongoing study called Real MS, which asks people to update their health and wellness information twice a year. And that data is being shared with researchers looking at MS from a number of different angles. And it grows more valuable each year as more people participate and share their information. So participating in Real MS is an easy way to make a big difference. We're also going to be starting a new survey soon about employment and resources that people with MS have used or can use to stay employed. So keep an eye out for that in the next few weeks. And that brings us to our main event, a presentation by one of our research partners, Annabel Decamps at the imaging company Icometrix. iConquerMS and Icometrix collaborated on a survey a couple of years ago about whether people with MS could access their MRI images and also whether they could understand them. And it was such a pleasure working with them on this project, and they've done some exciting things in the meantime. So Chat, thank you for inviting Annabel to be here, and I'll hand it over to you for the official introductions.
All right, thank you so much, Holly. Again, for those of you who have been here before, but if you don't, my name is Surachat Ngo Surachet. I'm a faculty member at the Harrison College of Pharmacy at Auburn University. Again, thank you so much for being here. So for the next about 40 minutes, so we will have a presentation by Annabel Decamps from Icometrix. But just for your, just from if you haven't been here yet, by now, I actually by now I think some of you already know that why do we call our webinar as a chat with chat, because I actually don't go by Surachat, but I go by chat. So it's today chat with chat webinar. Okay, so as I said, Annabel Decamps from Icometrix is with us today. So she has a background in biomedical engineering, and she started working at Icometrix about 3 years ago. and on an app called iCompanion. So it's a way that she told me that it's a way for people with MS to monitor their disease at home, but they also use it to learn more about the MRI and also view their own images, so which is kind of very interesting. And again, today she's going to talk about brain scans in MS, the relevance, and also patient experiences. So Annabel, the floor is yours.
Thank you very much for the introduction. I'll start sharing my screen. Let me see. Can everyone see my screen fine? Yes, okay. So I'll get off to a start. First of all, thank you very much to iConquerMS to give us this opportunity to indeed share the results of the survey we did on MRI in MS a couple of years ago, I think 2 years ago, with about, I think, 876 participants. So that's very nice, mostly located in the US and in Canada. And so I'll go on and tell you about the results, but I'll also just tell you a bit on MRI in MS, so we can all learn a bit more. I am not a doctor as my background, but as Chet mentioned, I have a background in biomedical engineering. So I do have read a lot of things about MRI, and it's also very much part of my job, but I just wanted to disclose that. Yeah, so today we'll try to demystify MRI a bit. And I assume everyone here is excited to learn about MRI. And that's great because I believe it can be very empowering to have more knowledge and that way be more active in your own disease management. So I'm very excited to have you all here. So let's start with one of the first results of the survey. It showed that more than 70% of patients has looked at their MRI on their own, but then of that 70%, only 13% understood them completely. So this shows that there's still a lot of room for improvements in case of MRI knowledge. So let's go. First of all, I want to start with a quick introduction of the brain, of course, because that's where it all starts. Most MRI images for MS are taken of the brain. So I'll start with a small introduction. The brain mainly consists of neurons, which you can see here. This is one neuron. And each neuron consists of a head, which you can see here in purple, and then a tail called the axon. And then here are some small branches at the end. And these yellow sheets are called myelin, and that's meant as a kind of an insulation layer for the neuron to help the signals be transmitted faster. So it's kind of the same as an insulation layer around an electrical wire. Now, in the brain, we have gray and white matter. And the gray matter is actually all the heads of the neurons. And the white matter is then the insulation layer, so the myelin, which you can see as a connecting cables between the different computers, where really the information processing happens in the head of the neuron. So yeah, it's very important that all of this is connected. It's a communication between the neurons within the brain, but also the neurons, between the neurons in the brain and the neurons in other parts of the body. And exactly this sheet, this myelin sheet, is what is affected with MS, because the immune system recognizes it as foreign. So it attacks the insulation. And this is also what we can see on the MRI. So this happens in the white matter, in the insulation layer, and shows up as white matter lesions on the MRI. But also gray matter is important in MS. It can also be seen on MRI. And we can assess brain volume loss in the gray matter, which is also very relevant to follow up for MS. And actually, MRI has been used to look inside the brains and the spinal cord of people with MS since 1981. And since then, it really has become the primary diagnostic tool for MS. And why is that? Because it's the most sensitive marker for disease activity. It's also non-invasive, so there's no cutting or puncturing involved. And then lastly, there's also no radiation involved, which is positive as opposed to, for example, CT images. And it is used to evaluate the effectiveness of treatment. So we can see on the MRI how MS is evolving over time, which is very valuable. Of course, since this start in 1981, quality of MRIs has increased a lot, which is very exciting. There's also a lot of softwares which can really quantitatively assess, for example, this brain volume loss or enlarging lesions, things like that. But there's still a lot of improvements that can be done. So nobody's perfect, I guess. And then I thought it would be cool to maybe try to explain to you how an MRI is made. So it's quite a complex process, but I'll do my best to make it sound as simple as possible. So you just have an idea of what it's based on, and what mechanisms it uses. So it's actually based on the fact that our body is made out of about 60% of water, and that this water is magnetic. So actually the hydrogen atoms are sensitive to magnetic fields. And the MRI scanner can be seen as a large, strong magnet. So all these water atoms, they align with this magnetic field when you lie inside of the MRI scanner, a bit comparable with the compass needle aligning to the magnetic field of the Earth. So the strong magnet makes sure all the atoms are aligned, but then a radio wave is used to disturb this alignment. That radio wave is taken back after a while, and the alignments, the atoms go back to the alignment, but while going back, they emit a signal. And this signal is the MRI image. Why can we see things on an MRI image? Because the intensity of that signal depends on the amount of water in tissue. And this amount, for example, differs between white and gray matter. So MRI allows us to really have a nice image with different tints of gray and white for different tissues. So just wanted to tell you because I think it's a really cool concept. And actually, you can see an MRI image as a combination of all 2D slices. So basically, your doctor can literally scroll through your brain, as you see here. And what is cool about MRI is that it's able to visualize the brain in all the 3 planes. So you have 3 orientations. There's axial, which is the cross-sectional view, coronal, which is the face view, and then finally sagittal is a side profile view. As a lot of you probably know, sometimes MRI is administered with contrast. So first, a contrast agent is injected before the MRI is taken. And this contrast is also called gadolinium, and it's administered with IV. So it's administered directly into a vein. And that's why it's good to drink a lot of water before and after this, just because this plumps up your veins, which makes it easier to do the IV. And afterwards, the contrast is filtered by the kidneys. But you're probably wondering, why? Why is this contrast needed? Well, actually, it's able to show active inflammation. And this is very relevant when there's no recent scan to compare to, because it shows whether the lesion is active. So whether it's new or old. If it's old, it won't show up. But if there's a recent scan where, for example, 2 lesions can be distinguished, and then on the new scan, on the latest scan, there's 3 lesions. Of course, you can also conclude that this 3rd lesion is a pretty recent one and is an active one. That's also a way. But if there's no way of figuring out whether a lesion is recent or maybe from 10 years ago, then contrast is very good. And just also in general to see if there's disease activity, if it's really happening at that moment, and whether it's not like an old lesion that happened a while ago. And on the MRI, these lesions will appear as bright white spots, but I'll show you later. So as you might also know, there's different types of MRI scan. So actually during one scan, there are several types of images made. So your radiologist and neurologist can like take different information from these different types of scans. And that's why an MRI usually takes so long, because there's several different images constructed with it. So I'll quickly go over the 4 main types, but I won't go into too much detail. It's pretty technical. So first, there's a typical T1 scans, which are able to assess black holes, which then appear as dark. And that way, a radiologist can see if there's permanent damage to either the white or the gray matter. And that kind of scan looks like this. So there you can see the black hole. Then there's T1 with contrast, which I just talked about. So that way you can assess active lesions, which show up bright and which we call contrast enhancing lesions, like this. And then lastly, there's T2 and flare, which both show old and new lesions. So here there's no contrast added. So it's not just new lesions, but just all lesions that are in the brain. But they also show up bright as hyperintensities. And the only difference actually between T2 and flare is that flare is a bit better at suppressing brain fluid. So that way lesions are visualized better. But again, they both show lesions as these bright spots in the brain. This probably seems very logical, but of course it's recommended to cover the whole brain when taking an MRI, because otherwise information might be missed. So when there's like guidelines on MRI, it always mentions to at least cover the whole brain, but it's best to also cover the top of the spinal cord as well. Resolution is also an aspect of MRI. So as I told you, quality of MRI has become way better over the years. Also in the sense that the resolution has become way better. So just like an image can be pixelated, like not an image of the brain necessarily, but any image. If it's less pixelated, then you can see more detail. And that's just exactly the same way with MRI. So there's also guidelines on how good the resolution should be to be able to make good clinical decisions. And then lastly, these slices, so these different 2D images I was talking about, can have a certain thickness. And also making this thickness smaller is better because there's less tissue involved in one slice. So there's less blur of different tissues lying over each other. So it's also recommended to have small slice thickness. And also to not have too many gaps in between. So here on this GIF, you can see it's jumping through the layers, while here on the right, it's nice and continuous. And that way, nothing important can be missed. Then less technical detail, and then we'll go into the more interesting stuff, is the field strength. So as you may know, the field strength of an MRI scanner is measured in Teslas, which is actually the strength of the magnetic fields of the big MRI magnets. And the guidelines is that this strength should be at least 1.5 Tesla. And yeah, higher is even better, but they say that 1.5 should definitely be enough. Okay, so that leads us to another result of the survey, which said that about 98% of people with MS is interested in changes in their MRI, which is really nice to see, because of course, looking at the MRI is definitely as relevant as looking at symptoms. You should combine the two, and it's very cool to see that a lot of people realize that and are interested in knowing the changes. So when we look at MS lesions, they can actually be located in different areas of the brain, and these locations are not necessarily exclusive for MS, so can also be for other neurological conditions. So the radiologist really takes a look at the location of the lesions. And it's very important for example, the diagnosis of MS, that lesions are found in at least 2 different regions. And this is, for example, a person with MS where the different lesions in the different regions are color-coded. And this was, for example, done by a software I talked about, like a quantitative software, which can detect lesions and also color them according to where they are located. So it's very cool that that's possible. Then we come to brain volume loss. I actually got quite a lot of questions already. I already saw some of the questions that were sent in, and a lot of it were on brain volume loss, which I get because it's a very hot topic. So basically, how does our brain change? Well, as we age, we also get wrinkles on our skin, and also our brain ages with us. So just the way that there's people that have older or younger skin, there's also people that have more brain volume loss as they age than others. But it's actually a natural process that starts when we're about 20. But which can occur more rapidly in people that have neurological conditions. And it is, at this point, it's a hot topic and an important marker in research for treatment evaluation. And it has already been shown that it is very much of added value. But currently, it's not used in clinical practice yet because it requires appropriate MRI monitoring, analysis, and algorithms. And it also requires comparison between scans. But of course, if, for example, these scans are taken on another scanner, that comparison already becomes hard. So because it's about a change and not just, for example, a lesion detection, it's a bit more complex. So that's why currently it's still under debate. But yeah, the relevance has definitely been shown already. Another topic that I got quite some questions on is that there's often a discrepancy with MRI and symptoms. And it is indeed true that the number or the volume of MRI lesions is not always related to the severity of symptoms. So the MRIs that are analyzed for MS monitoring, they're mainly based on these new lesions, these active lesions, and not that much on what happens with gray matter, as I just mentioned, with the brain volume loss. But in the gray matter, there's also a lot of critical parts that, for example, control speech, motor function, memory, and so on. And this can also be problems for people with MS, but they don't really show on the current MRI scans. So higher quality of MRI analysis, more standardization of scans could be a solution here, but currently, yeah, we still lack the adequate measurements to really assess all the damage. So some damage might be missed, which is actually there. So that's one part of it. But next to that, yeah, our brains are amazing, and there's high plasticity of the brain. So when it encounters damage, it finds a way to respond to this damage and to compensate for this damage. So that's why it's very important to not only look at symptoms, but also at MRI, because this means that there might already be something going on in the brain, but our brain finds a way to reorganize and compensate. But of course, there might be a moment that this compensation stops and you start getting some symptoms. And that's why it's very good to quickly already see what's happening in the brain and try to treat it. So that's again why I love that 98% were interested in seeing changes in MRI, because both symptoms and MRI are very valuable to make treatment decisions in MS. What is actually true is that the location of MRI lesions can actually be related to the severity of symptoms. So, for example, lesions in the spine can be more severe because it's actually just smaller volume, so it has a more direct effect. But then also infratentorial lesions are known to be a bit more severe. But that's not always the case, but there are some locations linked to higher severity. And that brings us to the spinal cord. So it is actually very relevant to also take an MRI of the spinal cord, because it's also part of the central nervous system. So just like the brain, it has the gray and the white matter. And also having an MRI of the spine can allow for earlier, but also more accurate diagnosis. And it's often also used to rule out other pathologies that might affect the spine. But as I mentioned, it's a pretty small tube, like compared to your brain, it's not that much a volume. So there's actually way less discrepancy between what you see on the MRI and the symptoms you're experiencing. Because if you have a lesion there, there's like a greater chance that it's directly shows up as a symptom, because there's less plasticity there. And it's mainly motor and sensor symptoms that come from lesions in the spinal cord. When you have an MRI of your spinal cord, it's often divided in 3 parts, just as your spine is. So the cervical part, thoracic part, and then below is the lumbar spine. So these are often assessed in separate MRI scans. All right, and this brings us to the MRI guidelines. So actually 95% of patients wants to know if their MRI is performed according to clinical MS guidelines. So I already mentioned the guidelines before, but I'll again stress why they're so important. So if we want to be able to compare different scans, we need standardized MRI protocols. So as I mentioned, if there's like different settings of the scanner, or it's even a whole different scanner, it's really hard to compare brain scans. So if we can standardize this, this will make this a lot easier, and also just improve the accuracy of, for example, the brain volume loss measurements. And it's also, of course, good for a more accurate detection of new lesions. These guidelines are actually written out in a paper last year, and there are suggestions on how to optimize the MRI workflow. So I do want to stress that these are suggestions, and I will be telling you what's recommended. But of course, if this may differ from what your neurologist tells you, I want to stress that every situation is different, and these are the recommendations. In the article, they're written quite complex and in scientific language, so I did my best to kind of list them in a more comprehensible way. Okay, so first of all, the timing. So I noticed also some questions on the timing of MRI, which is not always clear, like how often should an MRI scan be taken. So what the guidelines recommend is to have an MRI scan taken before starting a treatment or when switching to a different treatment. And then after treatment has been initiated, around 3 to 6 months after this. A bit longer, there's like slow acting treatments. And this can be done without contrast or with contrast if there was no previous scan, as I told you, because otherwise you cannot define which were the active lesions. Then after these follow-up scan for the treatments, it's actually recommended to have a yearly brain MRI when you're on treatment. This can be a bit longer if you're clinically stable. And then when there's MRI disease activity seen, but there's no symptoms seen, they actually recommend to have a 6 months follow-up instead of a yearly follow-up. So I hope that at least answered some of your questions about the timing. Then the recommendations for contrast. So actually it's recommended to have it in the first year of follow-up, and particularly in patients that are on interferon beta or glatiramer acetate, just because they're a little bit less effective in tackling the things that can be seen on MRI. And also for the detection, confirmation of symptoms. And they really recommend it in case of start or change of treatments. When is it not recommended? So not needed to do in case of a recent scan. So as I mentioned, but with recent scan, they really mean like less than a year ago. So otherwise it's always relevant to use contrast. And then also an exception is pregnancy and lactation. Then there's also some recommendations on the MRIs of the spinal cord. So it's recommended to do those to detect active spinal cord lesions, but also, as I mentioned, for the exclusion of possible comorbidities involving the spine or the spinal cord. And this is recommended in patients with, for example, few brain lesions or like disability symptoms worsening, which are unexplained by the brain MRI. It's definitely recommended to do a spinal cord MRI. Also, with the DMT switch, it can be good to do when there's signs of other pathologies, things like that. And here we are at the final result of the survey I will present. So we actually asked, like, if you've never looked at your MRI, what were the 3 main reasons you didn't? And then on the first place was not really knowing how to interpret the images. No, sorry, that's the 3rd place. And then the 2nd place was not really having the tools for it, so no software application to view them. And then on the 1st place, just not being sure what on the MRI images to look at. So I hope I kind of answered those in my presentation. For the 2nd one, I do want to quickly mention indeed the app that we are creating at Icometrix. So actually in the app, you can see your MRI images and you can learn a bit more about MRI. Yeah, if you scan the QR code, you can check out the app. So on our website, you can upload scans you have from website, maybe on a CD or USB. I've noticed that it can be very different for everyone. And then you can have your MRI scans in your pockets, which we have had some positive feedback on, because people feel like such an invisible disease, and by being able to share with family and friends, like this is what's happening inside my brain, can help making it a bit more visible for your environment, what's happening inside. I see that I actually only took 30 minutes, so I hope that's not a major problem. I try to find the right pace for my slides, but I guess I finished a bit early.
No, that's definitely fine. You're fine, and Annabelle. I actually learned a lot from your presentation. To be honest with you, that you really kind of lay out, about the MRI and also the MRI of the spinal cord. That is something that I learned from you. We got a lot of questions, Annabelle. So we'll see, how we are going to be to handle this. But just like to let everyone know, we have, previous question that people who register and submit that, but we're going to give priority for people who ask the question here. But still, in the chat box, we have so many questions here. But what I'm going to do is I'm going to go with everyone, where some people are actually asking more than one questions. So I'm going to go with everyone first question, okay, and see how much time do we have. And the rest of the question, I will kind of forward that to Annabelle and see how she can address those questions later on, and then maybe communicate back to those who ask those questions.
Yeah, okay.
Okay. So the first question for you, Annabelle, is a question from Patty. So she asked the first question, but her first question that you already answered, I believe. So I will pick her second question. So her second question is, in addition to, when you mentioned about taking water and the kidney filtration. So what is your thought about, the importance of the basic metabolic panel, which is a BMP, like for example, blood glucose, to ensure the kidney function or anything like that. So yeah, you have any thoughts on that?
Yeah, there's actually, like in the new guidelines, it is mentioned that's, yeah, it's good to really think about using contrast and not using it if it's not needed, because sometimes there is some signs of some contrast agents left in the blood. Not that that's very critical for health or anything, but indeed it's not only about drinking the water so that the veins are pumped enough, but other things should of course also be considered. But yeah, I do want to stress again that I am not a doctor by profession, so I can only answer that to an extent, I guess.
Yeah, that's good. Yep. Yep. So the second question from Janine, Annabelle. So she asked that, does a person's water intake prior to MRI have any impact on the quality of the MRI? I know you touch on this, but she's specifically asking about the impact.
No, that has not been shown. Like, it's not, I think it's a very smart way of thinking, like, could I intensify the signal by drinking? But no, yeah, it hasn't been shown yet. But I think that's a very cool thought.
Okay. All right. So the third question is from Katie. So her question is it better to have your MRI done on 4T MRI machine as opposed to the lower, kind of strength or the lower capacity one?
Sorry, can you?
Yeah, is it better to have the MRI done on a so-called 4T MRI?
Yeah. Indeed, like it's a stronger signal, but the guidelines, they still say, like, especially for diagnosis, it's not like a 4T scanner is better than 1.5 scanner. So that's why they still keep recommending that 1.5 is definitely enough. Of course, yeah, the quality increases indeed. But yeah, the guidelines still say 1.5 Tesla is enough for that.
Okay. So next question, we actually can answer many questions here, so which is good. So next question is from Helen. So she asked that what causes the various noises inside the MRI during a scan?
Yeah, that's a good question. Yeah, I guess it's the magnets like going around, but it's actually I think a combination of also the like the radio transmitter that sends out the radio waves, then the magnet, then the receiver of the waves. So I guess it's just a combination, but I'm afraid yeah, Google could answer it a bit better than me. But indeed, I know it's an annoying part of getting an MRI is how loud it is.
Okay. All right. Yep. I have heard about that. People complain about,
Yeah, exactly.
it's not only, feel like you put yourself in that space, right? There's some, noises as well. So next question is from Debbie. She asked that, does the MRI show changes in gray matter?
Yeah, exactly. So it's as I try to say, it's indeed like at this point, clinically, only the lesions are assessed. And of course, yeah, if a radiologist really notice like a loss of the brain, they will also mention it, but it's not really used to base clinical decisions on yet. And that's what I try to explain with the fact that volume loss, like gray matter loss, for that you need 2 scans. Because of course, if you see 1 scan, you cannot compare it to anything. So you don't know if anything is lost. And for that, there are, like the company I'm from actually works on this a lot. They make a software to try to quantify how much volume was lost, and actually also compare it to someone without a neurological disorder, because their brains are also, as I said, like as we get wrinkles, our brain also gets smaller. So you don't only have to compare it to, for example, a previous scan, but also to a person without MS and with your age, to see if it's like different from a normal loss. So yeah, there's softwares that can assess this, but it depends on like the quality and the whether the 2 scans had the same protocol when they were assessed. So on an MRI scanner, there's all kind of settings which can differ, and this can already influence the quality of the measurements. But actually, if there's 2 scans and they measure volume loss, like the software does it, and then the software does it again, it doesn't differ a lot. So that already shows there's a great test retest possibility. But yeah, it's not used in clinical practice yet, but it's definitely going there, I would say.
Okay. Next question is from Patty. Can you actually, Annabel, can you actually comment something about if a person with MS does not use any DMT, the disease modifying therapy or treatment, and and has never taken a DMT, basically, how often should an MRI be done for those people?
Yeah, good question. Well, actually, MRI is mainly used to like see the effects of treatment. It's also used for monitoring, right? But the guidelines are mainly focused really, like, as you could see, it was really with respect to the treatment. So before the treatment started, then 6 months after. So I get your thought like, okay, but what if you're not on a treatment? I guess in that sense, it should be way less frequent, because the reason you're doing it is frequent is really to evaluate, is this treatment doing something, or should we switch to another one? Because MS is very variable. There's a whole bunch of treatments. You want to find a treatment that's optimal for you and that can slow down your MS as much as possible. So yeah, in that way, MRI is really more frequently used for that. But yeah, again, I'm not a doctor, but I would think if you're not on a DMT, it still makes sense to monitor your MS, like see if there's active lesions, that maybe starts with the DMT. So yeah, that would be my answer there.
Okay, all right. Next question is actually is my question as well. Coincidentally, so the question to you is: should we actually have the MRI at the same location, or have the MRI read by the same provider? Is it something that we should do?
Yeah, nice question. So this also has to do with the standardization, right? So if you want to, for example, run a certain software that really quantifies what's happening, then that's very important. So I would say, as I try to convey, like for the comparison and for the changes, which are very relevant, it is of great importance. But of course, what we strive for, and that's maybe a bit ideological, but that every center where you could go is following this recommendations, is following these standards, so we can start going to the center ones and then have the other one somewhere else, but still having them be able to be compared. But of course, we're not there yet. But I would say that's a good question, because in ideal world that would be possible. It is still possible, right? But it is indeed nicer, yeah, to have them done under the same circumstances. That's positive.
Just to acknowledge everyone, that's actually the question from Patty as well, and she also had another interesting question, although she kind of mentioned in the chat box as a silly question, but I'd like to let you know, Patty, there's no question is silly. Just believe me. So the question is, since the myelin sheath is partially, right, as you mentioned before, composed of the fatty materials, so would that be possible that if somebody have the extremely kind of lose weight, would that kind of situation affect the MS or MS symptom, or or the the MRI or anything like that? You know what I mean? So
yeah, I understand, and I also think it's a very cool question again.
right.
I would have to look up the literature, but yeah, we do know that for like a brain healthy lifestyle, it's very positive to not have like to be on a good weight and to eat like a diet that consists of fresh and like varied foods. It has been shown to be very good for brain health, but that's at this point all I can say about it. And I should dive into literature to see if that's indeed a thing, but I don't know.
Yeah, I agree with Annabelle. In fact, if the literature somewhere, there's some researcher actually study on this, then we have answer, right? Otherwise, this question, in fact, is not only not a silly question, but it's actually a good research question, right? because that's why, you know, people, we are all encouraged to kind of control our weight, right? So maybe, you know, when we control our weight by control our diet or what we eat better, who know, right? Because there's a lot of time in the medical science, you know, we will learn that once, you know, the body fat, you know, you don't really have the excess kind of fat, you know, body will pull that out and use it some other way, right? So this is actually, I don't know, it could be a really good research question indeed.
Indeed.
Yep. We're running out of questions, so when we still have time, Annabelle, so I kind of like to check with my fellow participant here. Anyone would like to ask Annabelle yourself any questions besides, you know, just typing in the chat box? I know it's kind of confusing. Chat with chat box, chat function. There's so many chats here. Any other question from all of you?
Chat, we also had questions that people submitted in when they registered. I don't know if you, oh, and Kathy's got her hand up, so we should have
Yep, Kathy,
ask her
please,
question. But we also have the bank of questions that were submitted in advance.
Yep. Unmuted yourself, Kathy, and go ahead.
Hi, Chad. It's not Kathy, it's Rich. I just forgot to change the name. So I have a question. I want to go back to MRIs and lesions on the spine and the taking of the contrast. When you take the contrast, is it better to wait a minute before they throw you back into the machine, or is it immediately in your, does it immediately go where it's supposed to go?
Yeah, I guess I think I remembered reading that it takes some time, but I guess here again my lack of being a doctor comes up
Because
again.
I tend to try and make them wait, because my sister-in-law does MRIs, and she said, "Oh, you should probably wait a minute." So I tend to let me breathe here for a second, then you can, because when they're doing your brain, you have that face mask on, and I can't stand that part. But so I was just wondering if it's better to wait, or if it's even 20 to 30 seconds.
Yeah, I actually have a kind of a helpline here of like a neurologist working at our company, and she's telling me that indeed in the protocol, there's normally like really described a certain time that should be between the administration and then going into the scanner. But she's also not very sure, like if it's indeed a matter of a minute or longer. So I'm very sorry, but
that's okay. All that means is it doesn't hurt. It doesn't hurt to wait.
Yeah, exactly.
Okay, thank you very much.
All right. As Hori mentioned, and we still have like over 5 minutes yet. As Hori mentioned, we actually have people, you know, asking some question. There's a lot of question. In fact, it's like over 20 or almost 20. So I'm just going to randomly ask, you know, pick from those questions. So the question is like a person asking that, you know, he or she feel like his or her MS symptoms are getting worse, but the neurologist say that there's no change on the MRI. So can you actually comment on that issue?
Yeah, that's indeed also one I read a lot of questions about. So yeah, that could be different reasons. So it's either that indeed the change in the MRI is not picked up due to just the quality of the current MRI scanners and the analysis afterwards, not being able to capture that at this point in time. But it could also be the plasticity of the brain I mentioned. So that actually there already was indeed some activity in the MRI, but earlier it didn't really show up as symptoms. But eventually, like this plasticity came to its limits, and actually the damage started showing clinically. And yeah, so in the brain, because yeah, as I mentioned, there's more volume than in the spine. It's not always that's directly related. And I understand that people could then like start to lose the interest in getting the MRI, kind of losing the relevance of it. But yeah, I hope that I was able to convey the message that it's definitely very nice to combine both, to monitor the disease, to evaluate how the treatment is working. So yeah.
Mm-hmm. Yep. All right. So we have like less than 5 minutes now. So I kind of like to wrap this up. But first of all, thank you so much, Annabel, and also Icometrix, for your time with us, and also for your research. Very interesting research and also results. And we got a lot of questions, and we will. We actually forwarded some to you. We'll forward the rest to you as well. So just again, thank you so much for your time. So just the general announcement for today, we will have for the chat with chat, the webinar. So we will have a break next month in August, and then we will kind of convene or come back again on September 8th. At 4 p.m. Eastern time, and on that day in September, we're going to chat with Dr. Miller from Cleveland Clinic, Ohio. So please stay tuned. Okay. And last, I kind of like to, but not least, I really like to take this opportunity. I tend to forget, but this time I'm not going to forget. So I like to take this opportunity to thank iConquerMS and also our Next Step Committee. In fact, to create or generate or starting this webinar, the Next Step Committee worked with iConquerMS. So again, thank you. Thanks iConquerMS and also the Next Step Committee, which I'm not going to name them out here, but for supporting this event, including Lindsay Santiago and also Matt Gonzalez, for helping with legislation and also posting announcement on the social media and so on. So again, thank you so much, and thank you all for your participation and your time today, and hope to see you again in September. Thank you, everyone. Yep. Bye.
Thank you so much.
Bye.
Bye. All right, Sarah, I think we can close this one.
Yeah, I was just hanging out for a moment to see if folks wanted to copy the link, but thanks, chat. You did a great job.
Yep.
Bye.
All right. You have a good weekend.
You too. Bye.
Bye.